Okay, thank you very much, and thanks to the organizers for this opportunity to speak. So adolescence, defined by the WHO as ages 10 to 19, is a period of intense developmental, biological, and social transition. We often group adolescents with children, as we have in this session, but adolescents are often navigating adult experiences for the first time, and their developmental and socioeconomic position may present unique challenges. Rates of adolescent pregnancy are quite high in some parts of the world. For example, in Kenya, an estimated 36% of 19-year-olds have already begun childbearing. And the limited skills, agency, and power of these women may impact their uptake of antenatal care and PMTCT. Studies of ANC and PMTCT uptake by adolescents has been limited, but a number of studies from Southern and Western Africa have suggested lower antiretroviral uptake and higher rates of mother-to-child transmission in these women. So the goals of our study were first to compare engagement of adolescent and adult women in Kenya at each step of the PMTCT cascade, and that cascade is summarized at the bottom of this slide, beginning with antenatal care attendance, followed by HIV testing, and for HIV-positive women, uptake of maternal and infant antiretrovirals. And the second aim was to determine the correlates of adolescent engagement in the PMTCT cascade. So the context for this study is the CHIME PMTCT-MCH evaluation conducted in 2013. This consisted of 2 national cross-sectional surveys in Kenya of mothers aged 14 and over attending maternal child health clinics for their children's immunizations. The primary survey was a nationally representative survey of 120 clinics selected by probability proportionate to size sampling, and both HIV negative and HIV positive women were included in that survey. And then we also conducted a secondary survey that oversampled HIV positive women in 30 clinics in Nyanza province in Western Kenya. So women who participated in these surveys answered a series of self-report questionnaires, and their responses were verified by clinic booklets where available. And just for context, the PMTCT guidelines in Kenya at the time were option A or B or B plus if available, but option B plus had not yet been nationally rolled out. So I'll start by showing some characteristics of our adult and adolescent mothers. Again, as a reminder, adolescence in this study is defined as under age 20. So first, focusing on the results of our primary survey, which included both HIV positive and negative women. We had 2,521 women in this survey, of whom 278, or 12.8%, were adolescents. And adolescent mothers, compared with their adult counterparts, showed less stable partnerships, more first-time pregnancies, fewer intended pregnancies, lower rates of employment, fewer of them were HIV positive, and fewer of them had disclosed their HIV status to their partners, regardless of whether that status was positive or negative. Among HIV positive women, combining those women from the primary and secondary surveys, we had 498 HIV positive women, of whom 21, or 4.8%, were adolescents. Adolescent HIV positive mothers, compared with adult HIV positive mothers, showed less stable partnerships, more first pregnancies, lower rates of employment, and more of these women had been diagnosed with HIV during pregnancy rather than prior to pregnancy. So beginning with uptake of antenatal care attendance, this graph summarizes the proportion of women in adult mothers who received who attended no antenatal care, shown in red, 1 to 3 antenatal care visits, shown in yellow, or 4 or more antenatal care visits in accordance with national guidelines, shown in green. And what we see is that in adult women, the vast majority of women, close to 98%, do attend some ANC, but only under 50% are attending complete ANC, or 4 or more visits. By comparison, in adolescents, we see similarly that the vast majority of women are attending some antenatal care, but only a third are attending 4 or more antenatal care visits. When we compared this by logistic regression, we found that adolescents had a significantly elevated odds, about 1.5-fold increased odds, of not attending complete ANC. Interestingly, this effect was not due to late presentation among adolescent women. The gestational age at first presentation at ANC was similar in both groups, around 23 weeks gestational age. So what this analysis suggests is that there is a gap in the PMTCT cascade at retention of adolescent women in antenatal care. So next, moving on to HIV testing. Among the women who did attend antenatal care, we found similar levels of HIV testing in adult and adolescent women, with over 95% of women having received an HIV test. And finally, looking at antiretroviral uptake. So looking among HIV-positive women, combining again across the primary and secondary surveys. First, looking at maternal antiretroviral uptake. So in these bars, the gray represents women who were already on antiretroviral therapy for their own health prior to pregnancy. The green, women who received antiretrovirals for PMTCT. And in red, women who didn't receive any antiretrovirals. And again, what we see comparing adults and adolescents is that adolescent women are more likely to not have received any antiretrovirals. And comparing this by logistic regression, we see that adolescents have a roughly threefold elevated odds of not receiving antiretrovirals. And finally, looking at antiretroviral uptake for the infants of these women, what we found was that in adults, only about 2% of women didn't receive antiretrovirals for their infants, whereas about 14% of the infants of adolescent women didn't receive antiretrovirals. And again, comparing this by logistic regression, we found that adolescents had a roughly six-fold elevated odds of not receiving antiretrovirals. So this suggests a second gap in the PMTCT cascade with uptake of maternal and infant antiretrovirals by adolescents. So our second aim was to determine the correlates of adolescent engagement in the PMTCT cascade. So focusing on antenatal care attendance, which was our outcome with the greatest statistical power, we wondered whether some of the sociodemographic characteristics of adolescents that we'd reported earlier might be explaining some of the difference between adult and adolescent uptake at ANC. And these differences are summarized on the left here. And so our approach to tease this out was to stratify our analysis by each of these characteristics. So this forest plot represents the odds ratio and confidence intervals of adolescent incomplete ANC attendance in each of these groups. So at the top, we have the overall odds ratio, which I presented in the previous slides. And then under that, the odds ratio for each of these subgroups, so only among married women, unmarried women, and so on. And what we see is that across our strata, with the exception of employed women and HIV-positive women, where our confidence intervals are quite large, likely due to small numbers of women in these groups, the elevated odds of adolescent incomplete ANC attendance persists in our stratified analysis, suggesting that these sociodemographic differences don't entirely explain the effect of adolescent age. So finally, we asked whether we could identify any characteristics of those adolescents who did attend complete antenatal care attendance. And what we found were two trends. For higher rates of complete ANC attendance among married adolescents and adolescents who had disclosed their HIV status to their partner, again, regardless of whether that status was positive or negative. We interpret both of these characteristics as being markers of stable, supportive partnerships. So our study has a number of important limitations. The first is that we had small numbers of events in some of our groups, for example, in HIV-positive adolescents. Nonetheless, we were able to detect some statistically significant differences, but these sample sizes may have influenced the precision of our estimates and also our ability to conduct stratified analyses within these groups. Secondly, the data that I presented today is based on self-report data. We were able to verify approximately 70% of our data in MCH booklet and found similar results when restricting to those data. And finally, a limitation of all clinic-based surveys is that we may be excluding the most vulnerable mothers who didn't present at the clinic at all. So to summarize, I've shown you that in this clinic-based survey of women in Kenya, 12.8% of mothers of any HIV status and 4.8% of HIV-positive mothers were adolescents. Adolescents showed lower engagement in 3 steps of the PMTCT cascade: ANC attendance, maternal antiretroviral uptake, and infant antiretroviral uptake. Our analysis suggests that adolescent age is an independent predictor of incomplete antenatal care, suggesting that age alone is a useful identifier of women who may need additional support. And finally, our data suggests that married and disclosed adolescents may show better antenatal care attendance, suggesting that maybe interventions that supplement adolescent support structures may be promising. So I'd like to close by thanking the survey participants, my co-workers in the CHIME study team, and I'd also like to draw your attention to a number of other posters being presented from the CHIME study at this meeting. Thank you.
This paper is now open for comments or questions.
Celia Christie from Jamaica. Thank you very much. I was wondering, what is the legal age of sexual consent for your adolescents? Reason being, I wonder if maybe younger adolescents who are pregnant may not necessarily want to access health care for their own health and for their child, maybe because of legal ramifications. Thank you.
So I actually don't know what the age of consent is in Kenya. I don't know if someone else, I'm sure other people in the room do know. I can tell you that in Kenya, pregnant women are considered emancipated minors, so there is this understanding that in terms of sort of consent, women who have children are above the age of 14 are considered adults. I think the issue about whether adolescents want to attend healthcare is a really interesting one, and I think that our data that adolescent and adult women are presenting at the same gestational age at first ANC suggests that probably the breakdown is actually in what these women experience once they do attend care. That's what I would guess. I think that anecdotally and based on qualitative data, there is evidence that adolescents experience quite a bit of discrimination and have some pretty unpleasant experiences in healthcare. And so that certainly, I think, would be a detraction.
Hi, Sylvia LaCourse, University of Washington. You sort of just touched on it with your answer to the previous question, but among adolescents who weren't on ARVs, since these are self-reported surveys, I was wondering, were you able to tease out reasons why they weren't on ARVs?
We haven't looked at that. We don't have qualitative data. It's really just, were you on ARVs and which ARVs were you on if you weren't, but we can look more carefully to see. I mean, one question is, were they offered ARVs or not? And so I think we can look more carefully at that, but our data is pretty limited.
Thanks.
Go ahead.
Kate Powers, Massachusetts General Hospital. Thank you. Very good study. You had indicated that the median booking time into ANC was comparable between the two groups, but did you look at the adolescents who did not receive ARVs to see if there was a trend for those to be later bookers?
Yeah, that's a good question. I actually haven't looked at that. I can say that our outcomes correlate with each other. So attendance of complete ANC was a predictor of receiving antiretrovirals, but I haven't looked at the first gestational age as a predictor.
Okay, the back mic.
Allison Alva from Johns Hopkins in Baltimore. Thank you so much for that. Just a couple of questions. You alluded to some qualitative anecdotal stuff. Wondering if there's any plan to ask the providers that care for the adolescents in terms of their perceptions of youth, in terms of figuring out what ways we can potentially address this in terms of whether youth-friendly services or other things. Just curious for your thoughts.
Yeah, I think that's really interesting work, and we haven't done it yet, but I agree that that's a really important area.
Yes.
Just to provide some information for you, the legal age of consent
Thank
for
you.
sex in Kenya is 16.
Okay,
I
thank
just
you.
wrote a paper on this, so that's
Great.
what I remember. Thank you.
Thank you.
Okay, go ahead.
It's 18
It's 18 now.
in the Children's Act.
There we go.
I just had a very quick question.
I think it's not, there's no legal age for sex, but the child is described as anybody below 18, and sex with anybody below 18 is illegal. Illegal.
That's the point I need to make.
Right.